Hello, everyone. We're going to be getting started momentarily. Thanks for joining us. As you're hopping in, use the chat function to let us know where you're coming in from, what your title is, what your role is, so that we can interact with you a little bit. Please share all the good information. Welcome, Demetria. Thanks for joining us. Welcome, Kyle. Jean, Vanessa, thank you guys for joining us. All right, well, it's 2 minutes after, and we have a lot of content to get through, so we're just going to go ahead and get started. As we get started, please, everyone, continue to feel free to drop in where you're joining us from, what state you're in, what your role is, and maybe you can share a little bit about what you're looking forward to learning about today as well. So as we do that, I'll just share a few housekeeping notes. Please note that the webinar is actually being recorded and it will be shared with you. I'll likely share it tomorrow after I clean up just a couple of things on there. And if you have any questions throughout this webinar, please use the Q&A box that's located below. And if you want to share any resources or have general conversations with other attendees and the panelists, feel free to use the chat box as well. So with that, I'm going to turn the mic over to Laerdal's VA expert, John Gillespie, and let him take the reins. John?
Thank you, Helen. Thank you. So today, this is the list of topics that we're going to be covering during the webinar today. In just a few moments, we'll be doing our introductions. We'll have an overview of the healthcare standards of best practice, then detailed review of the simulation design standard, highlighting the criterion, and useful resources at the end. With that, I'd like to introduce our speakers today. We're very flattered, very honored to have Dr. Kutzin join us. He's with Mount Sinai, and he's also the incoming president of the Simulation Society. So thank you, Dr. Kutzin, for joining us today. And then we also have Dr. Penni Watts. Penni has been with us for all three of our webinars now. Penni was the chair of the committee during the last review of the standards of best practice, and certainly a content expert on all of the standards. And we're honored to have her join us from University of Alabama, Birmingham School of Nursing program. Thank you, Dr. Watts.
So everyone, thank you so much. I'm glad to be here with you today. And as we begin our conversation, we want to do a quick poll for you guys. So what do you hope to gain out of joining this webinar today? So I think Helen is going to launch this. And then
you guys can just drop it right into the chat as well.
Oh, let's drop it in the chat.
Yeah.
So what do you hope to gain from this webinar today? So we'll give you just a little bit of time to pop some things in. So as you guys are hopefully popping some things in, I don't see anything in there yet. So maybe it's just for us to give you some information. So if you think about it, let us know. Oh, here comes some new ideas on use of simulation. Okay. Best practice for design, tips, tricks, new ideas in content. Seeing what changed in the last couple of years. Okay. So you guys keep posting those in and I'll keep an eye out. And I think we'll be able to answer several of these questions for you as we move forward. So keep them coming. So just sort of a review for those guys, for you who have been on the webinar with us before, the healthcare standards of best practice, these are the main ones that we have. We don't put the glossary on here. So there are really 10 standards of best practice, and today we're going to be focusing on simulation design. And as you can see on the website, of course, there are all the other standards that you can use to help facilitate your practice. But today we're going to focus on sim design. So when we think about simulation, and I know that Jared may have his way of introducing to novices or new people or people that have been doing sim for a long time, which standards, do you go to first? Sometimes I will use sim design first. Sometimes I'll go to professional integrity, but sort of the core 4 outlined by Naxal are on the screen here: debriefing, which I think is one of the most important parts, as well as facilitation, professional integrity, pre-briefing, preparation, and briefing for the simulation. And I think they're all important, and I think it depends upon what you need from each of them. So just a little bit on the core 4, and of course the rest of them we have available on the website, and we're going to get through these through the end the next however many months to get through the rest of the webinars, or rest of the standards for the webinars. Next we have, I'll let Jared start with sim design, and I'll be popping in to add some commentary.
Thanks, Penny. And Helen and John, thanks for inviting me today. I'm not quite sure why you gave me the standard with the most criterion underneath them.
That's because I love you, Jared, and you're my best friend.
It means you've given me the most work and the most words to go through. So we should just jump in, and what I'd like to say is, for the 40 or so people who are online, like, feel free to put your chat questions into the chat at any time. We'll stop, we'll discuss them. And if we can take you off of mute or however we want to do it, this is an informal, we'd like it to be a discussion as much as possible, recognizing that it is a webinar and we'll be talking at you a lot. But let's dive into the first criterion, and looking at the idea that simulation needs to be designed with content experts. And that's what hopefully you all are or are becoming. But I think that the largest challenge here is we end up with a lot of individuals who are thinking that simulation is just, another side thing that they can do, and that they don't need any true expertise in it. And we know that's not the truth. I could recount a couple of stories. The ones that happen most frequently are really our new nurses coming into the hospital setting. So I work at the Mount Sinai Hospital in New York City, and faculty member in the Departments of Emergency Medicine and Medical Education. So I predominantly focus on our residents and our physician learners, but we do see a fair number of our nursing learners, and we run a new graduate health, a new ED nursing program for recent graduates. And the one thing that we hear pretty regularly is that they have a dislike for simulation coming out of nursing schools. And I don't want to generalize, but we've seen this posted on message boards and other areas. And I think one of those reasons is because simulation for many years has sort of just been designed in a little bit of a vacuum. Maybe it was an educator who had an interest in it and never had formalized training in it, or it's a physician who got interested in it, again, didn't have any formal training and has sort of been doing it their way for a number of years. But what the evidence shows and what we've come to realize is that this is a specialty unto itself. And that's why the simulation societies exist. And that's why the standards of best practice are put out, because we've come to recognize that simulation could do a lot of damage if it's not done in a proper format. And that's what the standards of best practice are trying to do, is to help individuals, both novices and experts, adhere to sort of established criteria. And the reason, and one of the ways that we see that this is becoming more and more common and more true, is, if you go to the next slide, Helen, is this notion that New York State just put out. This is Governor Hochul here in New York, who put out signed a law into practice. And I know you can't read it, but we're going to highlight the area here where it says, if you are going to replace clinical hours in nursing school with simulation, then it must be designed, guided, and supervised by faculty and program staff with appropriate and relevant training, certification, or accreditation. So what the law in New York says is that you can replace up to 33% of your clinical hours with simulation if you are a nursing school, as long as it's done by and done in a good manner by a certified or accredited or well-trained individual. And so I think this is the first of many that we're going to see. We know from a nursing perspective that there's been studies that show that you can replace clinical hours 50% of your clinical hours with no adverse effect on your NCLEX pass rates. But this is the first time that a law, to my knowledge, that a law has been signed that has really mandated this idea. And I see that Penny said that same thing happened in Alabama through their board of nursing. And so I think we're going to start to see this become more and more common as we continue to recognize and proliferate the idea that simulation is a specialty unto itself, and it requires specialized training and education to use it successfully. So criterion 2 and 3 is talking about a needs assessment to provide this foundational evidence for a well-designed simulation experience and to construct measurable objectives that build upon the foundational knowledge that the learners come to us with. And so this is really, really important. This is sort of our learning theory, curriculum development 101, if you will. The model that I prescribe to and subscribe to is going to be seen on the next slide, which is called Kern's 6-step model for curriculum development. Kern's 6-step model curriculum development, while it shows it in sort of a linear fashion, it really means all of these pieces are interconnected. And so if you don't begin with a good general problem identification, general needs assessment, then the foundation for why you're developing this curriculum isn't there. And then we want to sort of narrow this down and talk about what's the targeted assessment of our learners is and why we're constructing a curriculum locally. Then we want to develop our goals and specific objectives, then choose the best educational strategies, implement it, and then evaluate it. But notice how all of those arrows sort of interconnect and go back to one another because everything has to be related. Out of curiosity, from the folks on the line, you can, just type a yes or a no, if you will. I'm curious, how many of you have been approached to develop a code team training? So just type yes if you've been approached to develop a code team training in your organization. I'm hoping I see something like 40 yeses pop up in the next minute. 3, 4, 5, 6, 7. There we go. That's what I was expecting.
That's my favorite sim.
Right? So I get this a request all the time. So we're in a 6 or 7 hospital system here, and all the time we're like, we need code team training. And so my first step is to like talk to our faculty and the person requesting, be like, so tell me more about this. Who is this for? Right? And inevitably the discussion is like the nurses on the floor need XYZ training. And so when I talk to them and I'm like, you need the nurses to have code team training. Well, they're not, those floor nurses are not part of the code team. The code team comes from the ICU. There's a dedicated nurse, there's a respiratory therapist. So tell me more about this like need, this general need that you have for code team training. And then they start talking and they're like, well, it's really about like what to do before the code team comes, right? What to do in those first 5 minutes before the code team arrives. So then I go, okay, well, wait a minute. The problem isn't like code team management and who the leader is. It's really about like recognition and how to set the room up for success. And those are really different objectives. One is going to be focused on team steps and communication and team leader and role clarity. And like that's important throughout. But like the code team doesn't need training on how to recognize a cardiac arrest and how to like put the side barrels of the bed down and move the bed away from the wall, which is what our staff nurses on the floor need. And so when we start talking with our educators and our management and we dig into it, we identify this like needs assessment of our targeted learners and we realize, oh, wait a minute. We need this training for these local responders. And then we also need this training for our code team and our larger system responders. And those are probably going to be 2 separate trainings with 2 separate sets of goals and objectives and actually different educational strategies. And I see someone wrote, you have to drill down to what they really want, right? They have not made their clear objectives for training is exactly right. And that's why our perspective from simulation has to be really laser focused. And the beauty of following this methodology, right, and developing your objectives and your educational strategy and your implementation is that leads to your ability to publish and present your work, right? You develop some novel training curriculum for, we just did a ventricular assist device training for our nursing staff, or ECMO training, or some new technology. Well, their history and the background of your paper is your general identification, general problem identification, general needs assessment, your targeted needs assessment, And then your next pieces of your paper are all about why you did this and how you did this, your methods, right? And then it's your implementation, and you get your results and your conclusions. And so doing this, while it sometimes takes a little bit of time, is really, really important. Go ahead to the next slide. So criterion 4 and 5 is talking about building the simulation-based experience, designing your case, designing your scenario. But I really want to highlight this next piece, or the activity to provide the context for the simulation-based experience. And a lot of times we harp on this idea of like, we have to build a scenario, we have to build a case. So I'm curious, again, you can type yes or no into the chat here. How many times do you have someone who comes to your simulation facility or comes to you and says, we have to write this case, we have to write this scenario, or they're worried about like the writing of the scenario? All the time. Okay, great. Yes. It's like we've done this once or twice before, like we're in your same shoes. Right. And I get this from our faculty all the time. Like, I got to write this case. I have to write this scenario. Or they want to use this case that happened on the floor, which there is value for that. But I get novice simulation users all the time, like worried about writing the case. And my response to him was like, let's not worry about writing the case, right? The scenario takes just a couple of minutes to write. Now we got to make sure it's aligned with our educational objectives and it's meeting our needs assessment, right? But like at the end of the day, coming up with the scenario is not the hard part. And so actually let's go to the next slide and let's talk about this in a little bit more detail. So this top paradigm, this traditional paradigm, is what we oftentimes think of when we talk about simulation. Pre-briefing, some sort of simulation scenario, and then a debrief. Maybe we have some reflective learning during that debrief. Maybe we do some skills practice after that debrief. Maybe we run them through it again, right? Maybe they do the scenario a second time. Maybe we have 12 learners come down and we split 6 of them up and 6 of them do the sim scenario and then 6 of them watch the sim scenario and then we rotate, right? That's an option as well. But this is what we like to frame as active observation or active participation. You're still like watching or doing, and you're reflecting on your actions, right? So the goal of this traditional paradigm is reflecting on your action so that in the future, when you see this again, you can reflect in the moment and be able to recall what you learned during the simulation to put it into practice. This is very different than this idea of deliberate practice on the bottom there. And yes, these slides will be available. The whole recording will be available at the end. So don't worry too much about having to take copious amounts of notes. So the deliberate practice idea is what we oftentimes use for our first 5 minutes training. So our traditional, if I go back to the scenario of co-team training, our co-team training may follow that traditional paradigm. We bring a bunch of learners in, maybe there's 6 or 8 of them who are going to be on the co-team. We talk to them about the pre-briefing, what to expect, how the simulation scenario runs, how the equipment works, so on and so forth. And then we drop them into a scenario and maybe we videotape it, maybe we don't, but we're focused on not the compression depth and the compression ratio, but we're focused on the higher level teamwork, communication, role clarity concept. Now, when we debrief, I usually have like a 70-30 rule. 70% is either focused on teamwork and communication with 30% focused on the clinical skills, or vice versa, 70% focused on the clinical skills if I have a bunch of med students, and 30% focused on sort of the teamwork and communication. But for code team, I'm focused on like 70% teamwork, communication, role clarity, closed loop communication, leadership, and those sorts of topics, with a small discussion of compression depth, rate, recoil, ventilation, so on and so forth. But when I have a group of novice nurses, novice learners, and they need to recognize how to respond to a code in the first 5 minutes, I'm going to do it differently. What we do is we do this rapid cycle deliberate practice model. It was developed by Betsy Hunt down at Johns Hopkins for pediatric advanced life support. I translated this into the nursing community for advanced cardiac life support. And so what we do is we take our group of 8 learners still, and I bring them in and introduce them to the mannequin, and then I ask for a volunteer. And then one of those, the person who volunteers will stay and everyone else will go wait in the hallway. And what we then do is we say to them, okay, here's your patient. The tech came out of the room. They said to you, this patient doesn't look so good. Go assess them. And they'll go to the bedside of the mannequin and try to assess them the best they can. Maybe they'll tap and shout, maybe they won't. Maybe they'll check for a pulse on the wrist, and then they will need to call for help, and they'll activate the local code team, and the other 7 people will come into the room. As soon as those 7 people come to the room, we stop and we talk. We talk about the first 4 critical actions that need to be done. Tap and shout, some sort of noxious stimuli, whether it's sternal rub or pinching the arm or pinching the ear. We talk about checking a pulse, carotid, not the radial. And we talk about calling for help and calling out loud, not walking to the door and opening the door and inviting the team members in. We then reset the room. We take a second person and we begin the scenario from the beginning. And this time we expect them to tap and shout, noxious stimuli, checking a pulse here, calling for help out loud. And then we let them struggle. And as the team comes in, we give them about 10 or 15 seconds, then we stop. And we talk about the next 4 critical actions that we expect. And I've termed this the 4 downs, 4 or 5 downs. We want to see the head of the bed go down. We want to see the side rail go down. We want to see the whole bed go down. We want to see the bed be pulled away from the wall. And I'd like to see the gown pulled down. So we cover those 4 or 5 things to set up the room. Then we begin again. We reset the room. A third person is going to be the primary person. They're going to do the first 8 steps. They're going to walk in, tap and shout, noxious stimuli, check for a pulse, call for help. Put the head of the bed down, put the side rail down, put the bed down, move the bed down, and begin compressions after they move the gown down. Then we're going to let the team struggle a little bit, and then we're going to correct those actions. And so we are repeating over and over until they've gotten the steps that we want them to master proficient, and then we let them struggle, correct it, and then the next person begins again. And so this idea and this method of simulation is very different than that traditional paradigm of drop them in and debrief. So as simulation educators, this is where we really create our expertise, and we have to figure out how we can get others to learn about all of these different ways of using simulation. We have here a picture of task trainers. Task trainers being a totally different methodology of utilizing simulation. Are we using it for formative assessment or summative assessment? Formative being informational, right, teaching, and summative being more pass-fail, competency assessment. So simulation runs the gamut, and don't forget, from standardized patients or standardized participants, the most high fidelity simulation that we could possibly have, all the way down to simple IV trainers and everything in between. But we also have different methodologies within it. Are you utilizing video-based simulation and practice while watching? So when we do IV training for our group of medical students, we set them each up with a IV arm and 3 different QR codes. And they come in with their phones, they scan the QR code, set it up, and they follow along with the video, whether they watch the whole video straight through and then practice on the IV arm, or stop and pause it and then practice as each step. That's up to them. And we let them practice while watching along with the video. We have a VR training component that we utilize for that. And then we have a competency demonstration assessment in another room. So there's a multitude of ways that we can use simulation, and it's up to the educator to have that really good discussion with the person who's requesting the program to develop the objectives and choose the methodology and process that is best for them. I'm going to stop for a quick second because I'm wondering if Penny has anything she wants to add to this.
Well, no, I was just thinking, and I get in the same habit of doing the same way, the same time, all the time. And introducing something maybe not be as simple as this, but really adds to the simulation, I think is very important. I know one time we had students that were coming into sim, it was anesthesia students, and they were, I don't know what the case was, they were running a code in the OR, and they always tripped up on the defibrillator, defibrillator. So finally it was Chad Epps that did it. Finally he was like, okay, before we started every simulation, we just had a lesson and session on that and went through it and practiced it. So I think we do have to think differently in order to reach our objectives. And this was a really neat idea, Jared.
So let's talk about this middle section of this traditional paradigm, the simulation scenario, for a second. This is the part where someone's like, yes, all the time they're coming to me saying, I'm worried, I need to write a scenario. We need a scenario for XYZ condition. So let's build a scenario. Do me a favor. We're going to build a collaborative scenario here. So list an objective
that you would like us to focus on? I don't really care. We'll pick a couple of these and we'll create a scenario around it. So like, what's an objective that you would compassion fatigue? Ooh, that's a good one. Okay, let's see what else we come up with. Like demonstrate or identify compassion fatigue, conflict resolution. Ooh, like with management or between two staff nurses. Management and employees. Ooh, okay. I don't do a lot of HR stuff. We've done it in the past, but those are tough. Anything else?
I'm wondering if you guys are ever approached by the safety committee or, you know, different people needing a specific thing for something that happened on their unit that you could think about. So.
Stop the line. Okay, so stopping like someone took a shortcut and you need to stop the line and speak up. Oh, that's a good one too. Okay, we've got a few of them here. Some of these seem a little complicated, and I'm not sure that I would really want to create that scenario. You see a mistake happening, you stop line. Okay, so let's do this. Let's do this. Let's have Helen. Let's take a little break from here, and we're gonna head over to ChatGPT. I'm curious, how many of you use ChatGPT? You can type yes or no into the chat. Okay, no, yes, yes. How many of you have used ChatGPT for writing a simulation scenario? Okay, a lot of no's. So let's do this. Helen, let's take this. Let's start with stop the line because I think that's a cool one. Let's see if ChatGPT can create a simulation scenario in the emergency department to stop for calling out a potential mistake. All right, and let's see what ChatGPT will come up with. For calling out a potential, how about medical error?
Okay.
Let's do that for a potential medical error. And let's
Right,
see what ChatGPT comes up with. So the scenario takes place in a bustling emergency department of a large hospital. Acute illness, there you go. And we're gonna let it produce this whole thing, including our learning points and our equipment.
And equipment too.
Yep, and let's scroll up and let's see the scenario. So it's a busy evening in the ED with multiple patients being admitted, evaluated, and treated simultaneously. Among the patients, there is a 65-year-old male, Mr. Smith, who presented with symptoms suggestive of possible myocardial infarction. The initial assessment indicates him in chest pain, shortness of breath. The emergency physician on duty orders 325 orally for suspected ACS, along with other standard cardiac workup. Okay, the primary is to assess the team's response to a potential medication error, specifically related to the administration of aspirin in the context of suspected myocardial infarction. So I think that's pretty interesting to see how much and how well ChatGPT creates a scenario. So let's look at the simulation steps. So a nurse following the physician order prepares to administer aspirin 325 to Mr. Smith. The facilitator introduces a potential error in the medication prep or administration process. So they're having the facilitator, standardized participant, sort of do something, maybe mislabel it, put a wrong label on there. A team member needs to raise concerns about the dosage or route of the aspirin administration. So I think that there is a component here, right, of it creates a scenario. Is it perfect? Probably not. But does it follow a lot of and provide us a really good jumping off point? I think it does. And we can then tweak it if we know what our objectives are and how we want to go about it. Now, I also really like, and Helen, if you would be so kind to scroll down and type this in, can you ask ChatGPT to create us a competency checklist for medication administration in the emergency department? So now, like, part of what our scenarios are is like we need the scenario, but we also need a checklist for our learners, for us to use to say whether or not our learners did things correctly. And as soon as we push go here, let's see what happens. Now, mind you, we did not pre-plan this in any way, shape, or form. These were literally just what you all asked us to do. You can go onto ChatGPT and do the same thing. And there's your checklist. There's all different sort of areas and competencies and, you know, pre-administration preparation, medication order verification, medication preparation, administration technique, documentation, patient education. This to me takes this idea of needing to sit and write scenarios and develop checklists sort of out of our hands. Now, great. Granted, we need to sort of modify things and update things. How can you get access to the program? It's free online. All you have to do is go to ChatGPT or chat.openai.com, and you can utilize it. And so where we're at with it is, you know, we're looking to see whether or not a group of experts can write scenarios as well as ChatGPT. We're looking to see if the competency assessment that it comes up with matches our needs. And so there's a lot of research that needs to be done on it. But in terms of the actual writing a scenario and people worried about writing scenarios, this is game changing. Not just that, but there's so many scenarios out there for use that have been written and published, validated. There are websites with different scenarios. There's a journal called MedEd Portal that I'm an associate, the deputy editor for, that has a whole bunch of scenarios, and all of the content needed to implement those scenarios are there for you. And so the site may be blocked at your VA, but you can do it at home. But you know, there's a lot of really good opportunities to think about how do we use artificial intelligence and incorporate this into what we're doing in the simulation community. So let's go back to the presentation, right? And we could have spent more time plugging more things in, but I think it does a pretty good job. We analyzed the scenario, analyzed the checklist, so we can move past that. And let's talk about criterion 6 and 7. Using various types of fidelity to create the required perception of realism and plan a learner-centered facilitative approach driven by the objectives and experience. So, you know, one of the examples that I like to use for this is what we just did like a week or two ago, and we had a VAD training, so ventricular assist devices. We have a group of nurses here at the Mount Sinai Hospital who have taken care of VAD patients for years, but they're not the fresh VAD patients. They are the patients who come in with other conditions who have had a VAD for a period of time. But for operational efficiency and throughput, we need to have those nurses start to take pressure VAD patients. So how do we make this scenario come alive and look and feel realistic to our participants? So we worked with our clinical experts and our subject matter experts, and we found the console and the VAD, and we were able to put it on and make it look like it was coming out of our patient's chest. And then we hooked it up to the console. But then we had the simulated VAD. So a VAD, a ventricular assist device, basically it just pumps, it's a little motor that pushes blood through the patient. And so what we did was we had a closed system outside of it, and depending upon if I took fluid out of it, it would cause a low flow alarm. If I added fluid to it, it would make it more normal. If I held the device a certain way, it would reduce the preload, again, causing a no flow alarm. If I held it another way, it would stop the flow, demonstrating a clot. And so we ran through 3 different scenarios, and one of the scenarios was a cardiac arrest patient with a functioning VAD. So the VAD is completely normal, but there's a specific algorithm that has to be followed for a VAD patient. And part of that is to assess for signs of perfusion, not a pulse because they won't have a pulse, but color, temperature, and other things, but also to make sure that the VAD is working. So we can look at the screen and it's all normal, but do we actually hear it functioning? So how do we make sure that there's a sound inside our mannequin's chest to simulate the sound of a VAD? Well, we took a kid's electric toothbrush, put it under the chest of the mannequin, and it created the nice humming sound like you would hear of a VAD patient. And our learners were blown away with the realism that these simple things created. They were like, how did you get a VAD into that patient and get the sound to make it sound so realistic? And so that is a way to make it come alive. Even today, we had a, a first year resident who should have known better, but he came in, and our scenario involved a esophageal intubated patient, and they were squeezing the bag, and he listened to lung sounds, and there were none. But he said, "Oh, I hear lung sounds," and there weren't any, and the chest wasn't going up and down. And there was no SpO2 on the monitor, no CO2 capnography on the monitor. And then somebody took out a glide scope and looked and was like, "Yo, it's in the right place." They were trying to assess to see if the tube was in the trachea. But at the end of the day, what we talked about with our team leader and our team was like, even though they like mistook some cues and other things, there was so many other signs and signals there that they should have picked up on about having this patient be esophageal intubated versus tracheal intubated. And so we need to just, make sure that our learners are aware of it, but making it come alive, letting them recognize all of the advances and abilities of the equipment. Even the simple things, like when we do a scenario, we did, again, going back to our bad patient, we did a scenario with a bad patient who had a stroke. When we close one eye on our sim mannequin, people recognize that as a stroke sign. So even those little simple things can clue learners in to a change in the patient's condition. Let's go to the next slide. So criteria 8 and 9 includes that pre-briefing plan, the preparation materials, and then looping that back to a debriefing or feedback session or guided reflection exercise to follow the simulation experience. This is your pre-brief and your debrief. And the pre-brief is a whole topic unto itself. And you'll spend a lot of time, you'll spend an hour talking about what goes into a good pre-brief. But I think it's really, really important that we have the conversation briefly about, setting the stage for their learner success. We like to tell people that this is a safe environment, even though their manager or educator could be present. We want them to know that this is not a test of their skills, that this is really just about them becoming better and practicing better. And then we also want to make sure that they understand the simulation equipment, what is available, what isn't available, how to go about operating in the environment. And then we also have, people that they may interact with, like our standardized participants, nurses, so on and so forth. And then the debrief, we follow a pretty standard format. And there's a number of them out there, and they'll spend a whole session talking about debriefing. And it doesn't matter which model that you subscribe to. If you've taken trainings at SimLearn, you're going to learn one method and model of debriefing. If you're an AHA instructor, you may utilize the AHA GAS methodology, gather, analyze, summarize. If you've come to a simulation conference, you may hear about the PEARLS model of debriefing. But in essence, they all have the same basic components. A reactions phase, like how are you feeling? What did you walk into? As some sort of an analysis phase of, what happened? Why did you do this? Tell me more about it. And then some summary. What did you learn? What did you take away? What are we going to fix for next time? And so there's 7, 8, 10 different models for doing it. Whichever one works best for you is what you should utilize.
And
and so, yep.
I was going to pop in on that. So we have a standardized pre-briefing list, like a guide, and then you're talking about debriefing. We have one as well, but we require our faculty or people that are in the sim, that's what they have to use. And I don't know, maybe you guys can tell us more, that it may be that it's hard to get people coming in doing what they want to do. We've kind of set that precedent that this is what we're using for pre-briefing, maybe tweak depending upon the situation, but we're trying to standardize that, if possible. So.
Let's go to the next slide. 10 and 11, I think we're coming to the end here, but it's really about creating a plan for evaluation of the learner and the simulation-based experience, including pilot testing experiences before full implementation. And if we go back to the current 6-step model of curriculum development, at the end, we talked about evaluation. And this really talks about two different things. This talks about evaluation of the learner and evaluation of the experience itself. So I frame this as a course evaluation and a learner assessment. And so it can be a formative assessment, it doesn't have to be a summative assessment. But for your scenario, for your skill, for your activity, there should be some sort of checklist based upon the objectives that you can sit, or someone can sit with and say, yes, they did this. Yes, they did this. No, they did not do this. Yes, they did this. That is your learner assessment, right? What percentage of, at the end of the day, you can say what percentage of your learners were able to meet XYZ criteria, 80% of the key items on your checklist. From a central line perspective, right? We would have like 40 items that are key items, and maybe 10 of them are super important that if you don't do one of those 10, you automatically don't pass. But then you need to achieve a minimum number of points. And at the end of the day, I could say this group of people achieved it, this group of people didn't achieve it. It took these people 6 times, it took these people 3 times, right? You can send them home with the checklist, they could study it, they could refresh themselves. There's a learner assessment. But then there's a course evaluation. And course evaluation, I'm going to use the term Kirkpatrick. Kirkpatrick is a theory process of assessing learning. And the idea here is that there's 4 different levels. There's the old school and the new age, but what it amounts to is the following. Level 1 is all about whether or not people liked it. So when they leave, do they fill out an evaluation saying, this was a good program, I would recommend it, I liked it, the instructor was good, right? Those are level 1. Level 2 is more about their comfort, their knowledge, their feeling like they could implement this, that it'll change their practice. Do you feel more confident after attending this program? Right? So you can ask the question, did you like this program? Yes. It was a comfortable place to learn. Yes. The instructor was well prepared. Yes. Do you feel more confident in your ability to run a code? Some people may say yes, some people may say no. Do you feel more confident in your ability to start a central line, start an IV, intubate, provide vague valve mask ventilation, whatever it might be? So there's this confidence, or do you feel like you can put this into practice? Level 3 is that idea of translating it back out to the clinical world, right? So are the processes and systems in place for people to take what you taught them in the simulated environment and implement it? And then level 4 is, does that implementation actually make a change to the patients? So just because you became competent or feel more competent or confident in your ability to start a central line, and just because we put the bundle of things on the unit for you to use, does it actually reduce central line infections? That's level 4. And so thinking through how you're assessing your learners and how you are having your learners assess your course, evaluate your course, are really important things. I see Bonnie writing here, through the TMS, you can embed the course evaluation, Kirkpatrick steps 1 to 3 into your course evaluation, right? And that's really a valuable component, right? So through your learning management system. And so we do this via QR codes because we want people to do it before they leave our course. But it's a good opportunity to make sure that you have both a learner assessment and a course evaluation. Next slide. So we're at 2:45. We have about 15 minutes or so left, but we want to hear from you. There was a lot there. We covered it relatively quickly, and want to pause and see what questions you have, what thoughts you have.
Someone asked about a list of suggested prompts for the audience to be able to make their own and utilize.
A list of suggested prompts for like Chat GPT, I'm assuming. It's a little bit trial and error. I've used it to create scenarios, to create checklists, to create competency of forms. Anything along those lines. And I think sort of the more details you give it, the better off you're going to be, right? So create a scenario for a novice nurse working on the post-op surgical ortho unit. It's going to give you a case more tailored about hip replacement or knee replacement than it is going to be about your MI in the emergency department. So I think the more specific you can get, the better it's going to be. I will tell you though, ChatGPT, from what I know about it and what I remember about it, it uses data from a couple of years ago to populate it. So if there's a really new treatment that came out for something, it may not be included. This is where your expertise has to be there to sort of go through it with a fine-tooth comb to make sure that that it's covering and teaching what you want it to teach. But from a foundational perspective, it gives you a lot of that sort of baseline materials. What's really cool, or really scary, is we asked for it to write it in a format suitable for publication in one of the journals, and it did like an 85% decent job of formatting it and giving like the right subject heading, the right content headings and everything else. So you cannot submit something that ChatGPT writes for publication, for the most part, I will say. It is a lot of journals don't allow for AI assistance to be used. It's a bit unethical in some ways, but if you're doing a study about ChatGPT's ability to write a scenario versus your content experts, then you'd be able to publish that. But you just can't sort of be like, here's what ChatGPT wrote for my scenario, and I'm publishing it under my name.
Yeah. One thing to add to that as well that I've learned from other sim experts is that the sources that come up and the references that come up on ChatGPT are oftentimes either very outdated or they're made up. So you have to do your due diligence and make sure that you are, making sure that the sources are actually legit before you actually utilize whatever it may be. If you're typing up a letter for a daycare or something like that, that's easy. You don't have to worry about your sources, which is how I use it. I use it in so many different ways. I use it for a graduation invite and a wedding invite as well. So there's so many different ways that you can actually use ChatGPT in your day-to-day life as well.
What other questions are there? You can raise a hand, you can put it into the chat.
I'm also wondering, have people actually used the design standard already? How many people are actually using it? And is this the first time you've seen it? Remember that the criterion, there's also elements. So there's a little bit deeper dive into how to achieve each of those criterion as well that can be helpful.
While we wait for questions, is it okay if I launch a poll? You guys okay with that?
Sure.
Great. So we want to learn a little bit more about what everyone's interested in hearing about in our next webinar. So as Dr. Watts mentioned, we'll do a pre-brief and debrief webinar soon, but is there anything else that people are interested in learning about that we should maybe prioritize? You can select the different standards here. Okay. I don't know if do you guys see the numbers changing? Or is that just on my end? Okay. Well, it looks like interprofessional education might be the highest there. And then evaluations coming up as well. Let's see. I think I might need to end a poll for you guys to see the results. Let's see. So what do you think, Dr. Watts?
Yeah, it looks like
it's a tie.
Oh, yes.
Yeah, IPE, facilitation, and then evaluation, professional development. So, and I guess I have a question for everyone too. So how many of you, do you have a curriculum that's already pre-designed? Do you have certain scenarios? Like a lot of our community colleges have a certain curriculum they have to follow in certain simulations, or do you guys have freedom in what you're doing, or people come to you and have an idea? I just wonder what you guys are experiencing in your hospitals. Both. Okay. So if you have some, standardized things, and then others that you have some freedom and ability to change. So, okay. Thank you, Lisa. Just curious myself. I know it varies from facility to facility.
Great. Okay, so we will, for our next webinar, we'll focus on one of those two standards. Just so everyone knows, we have already done a really nice webinar on a general. We did one on the general overview of the healthcare standards of best practice. The last one we did was on operations, and then of course today it's sim design. And we have those recordings, and I'll share those out with you guys as well with this recording so that you can access that in case you weren't able to join. Just to share a few resources. Oh, it looks like we might have some questions. Oh no, just a couple of comments. So thank you. So one resource we wanted to share is, of course, the healthcare standards of best practice. So you can scan this to be able to go to that page and then download the standards there. Or we can also drop the PDF into the chat for you. And then we wanted to also share some additional resources so everyone can jump in on this, and you can even tell us what your thoughts are in the chat. But we wanted to share some resources on different books. So you can see them listed here. These are all great books that have been recommended for us to share in this format. We always like adding more to it. So feel free to either take a screenshot or look for this in the recording to be able to grab these resources. And then a couple of conferences that we recommend that are great for sim experts like you all is the IMSH conference, which takes place in January. And then there's the Anaxel conference, which I believe is in June. And then the NLN conference, which takes place in September. And of course, I have to talk about our Sun conference that we do at Laerdal, which is going to be October 28th through the 30th. I'll say those dates again so that you guys can either attend or apply to be a speaker. It's October 28th through the 30th. We're currently looking for speakers for this conference, and the submission deadline is actually on April 8th. So if you're interested in being a speaker, please let me know, and I would love to have your application. And then we also recommend the SimOps and SimGhost conferences as well. Those are all great conferences with tons of great resources for you to be able to learn from. And then we also have some publications here that have been recommended. Of course, the Simulation in Healthcare, they have a lot of great resources on their site. There's a journal and a newsletter, and then they have this news publication called Storm as well that's online. And Anaxel has a great clinical simulation and nursing journal that they have. There are some podcasts out there as well. SimGeeks has one. It's operations focused. And actually Laerdal has a really nice podcast that's sim focused as well. And I'll drop those links in the chat for you guys as well. Let's see. I think I see another question. Yes. So we will share the recording with you in email. Keep a lookout for an email from me. I'll share it tomorrow. And I'll get that to you guys. But if you guys have any questions specifically about VA, about this webinar, about the healthcare standards of best practice, I would recommend reaching out to John, who you all met earlier on the call, and his cell phone number is here. Don't hesitate reaching out, and he can answer any questions that you might have. And then, of course, we wanted to share just one of our products with you. It's the Nursing and Simulator Geriatric. We have tons of great products that you could leverage in your sim center and in your teachings and learnings as well. And you can find all of that on our website. So yeah, I think that kind of brings us almost to the end. Do you have any last words, Dr. Watts or Dr. Kutzin? Or even John?
Go ahead, Jared.
No, I just I want to thank everyone for attending and thank Helen and John for having me. And I wish everyone a lot of fun and success in implementing your simulation curriculums. And following the best practices is a really good way to make sure that you're doing right by your learners.
Yeah, I agree with you, Jared. And I think, the standards are very lofty goals. It's hard to always get all of them. There's something to work towards. So, you just continue working towards making your experiences better. So, and thank you guys for participating.
Thank you, Dr. Watts. My thoughts on the standards of best practice, the whole reason behind doing this series is that it doesn't matter if you're really in a developmental simulation program or an advanced practice simulation program. The standards of best practice are evidence-based, and there's something for everybody. You don't have to go reinvent the wheel. The answers are here. You just have to go look at them. right? And there are experts like Dr. Kutzin and Dr. Watts that are happy to help, whether you're on a webinar or not, right? Right. And the same is true here at Laerdal. We are happy to help. So just let us know, and we'll be happy to jump in any way we can. Thank you all. I appreciate you taking the time to join the meeting today.
Yes, thank you. And be on the lookout for the recording and then also our next webinar invite. The date is to be determined right now, but we will be sending that information out as soon as we have it. So thank you all for giving us a little bit of your afternoon, and I hope you all have a wonderful day. Take care.
Thank you, everybody.
Thank you.